Hey everyone, and welcome to Dental Learn. Today we're going to talk about hypertension, also known as high blood pressure. This is a super common condition in the US, affecting almost 1 in 3 adults. That's a huge number. The bad news is this can lead to serious health problems like heart disease and stroke. The good news? There have been big improvements in catching and treating hypertension. More people are aware they have it, and more are getting the treatment they need. Now, hypertension affects a massive portion of the population, but the cause isn't always clear-cut. Let's break it down. In about 90% of cases, there's no single definitive reason for high blood pressure. This is called primary or essential hypertension. It's likely a complex interplay of genetics and lifestyle factors. In the remaining 10%, an underlying condition is the culprit. This is called secondary hypertension. Regardless of the primary or secondary nature, lifestyle choices significantly impact hypertension. These factors can contribute to the presence, severity, and progression of the condition. Packing on the pounds puts a strain on your heart and blood vessels. Heavy alcohol consumption can raise blood pressure. That extra salt on your fries can have a big impact. Couch potato syndrome. Lack of physical activity is a risk factor for high blood pressure. Here are some common identifiable causes of secondary hypertension. Chronic kidney disease. Your kidneys filter waste from blood. When they're diseased, they can't remove fluids properly, raising blood pressure. Chronic steroid therapy and Cushing's syndrome. Steroids and Cushing's can cause sodium retention and blood vessel changes, leading to hypertension. Coarctation of the aorta. A narrowing in the main artery leaving the heart forces the heart to work harder, increasing blood pressure. Drug-induced. Certain medications like decongestants, pain relievers, can raise blood pressure as a side effect. Pheochromocytoma and primary hyperaldosteronism. These are tumors that release hormones causing blood vessel tightening and sodium retention, raising blood pressure. Renovascular disease. Narrowing of arteries supplying the kidneys disrupts blood flow and can trigger hypertension. Sleep apnea. Repeated pauses in breathing during sleep deprive the body of oxygen, leading to blood pressure spikes. Thyroid or parathyroid disease. Abnormal hormone production from these glands can affect blood vessel function and blood pressure control. The scary thing about hypertension is that it can lurk undetected for years. The only clue might be an elevated blood pressure reading during a doctor's visit. The earliest sign of hypertension is an elevated blood pressure reading. However, fundoscopic examination of the retina may show early changes of hypertension consisting of narrowed arterioles with sclerosis. As indicated earlier, hypertension may remain an asymptomatic disease for many years, but when symptoms do occur, they can include headache, tinnitus, and dizziness. These symptoms are not specific for hypertension and may be experienced just as commonly by normotensive persons. Late signs and symptoms are related to involvement of various target organs, including the kidneys, brain, heart, or eyes. In advanced cases, blurred vision caused by retinal vessel hemorrhage, exudate, and papilledema may occur. These eye findings are indicative of accelerated malignant hypertension, a medical emergency that requires immediate intervention. Blood pressure is measured with a device called a sphygmomanometer. It gives 2 readings. Systolic pressure, the pressure when your heart contracts and pushes blood out. Diastolic pressure, the pressure between heartbeats when your heart relaxes and refills with blood. The American Heart Association defines normal blood pressure as less than 120 to 80. Higher readings indicate hypertension, categorized into stages. Some people experience elevated blood pressure only at the doctor's office, called white coat hypertension. For a more accurate picture, home monitoring or 24-hour ambulatory monitoring might be necessary. Before age 50, both systolic and diastolic pressure might be elevated. In patients with isolated diastolic hypertension, diastolic pressure is high, but systolic pressure is normal, typically seen in younger adults. Isolated systolic hypertension is common in older adults, In this situation, systolic pressure is high, but diastolic pressure is normal. The first task of the dentist is to identify patients with hypertension, both diagnosed and undiagnosed. A medical history, including the diagnosis of hypertension, how it is being treated, identification of antihypertensive drugs, compliance status, presence of hypertension-associated symptoms and signs, and level of stability of the disease should be obtained. Our main concern is preventing a sudden and serious event like a stroke or heart attack during dental treatment. This could be triggered by multiple factors. Stress and anxiety can release hormones that raise blood pressure. Vasoconstrictors in local anesthetics can cause blood vessel narrowing. Gingival retraction cords might contain vasoconstrictors that could be absorbed. Before treating a patient with hypertension, we need to assess the risks. How severe is their hypertension? Is it controlled? Is it a minor procedure like a filling or a major surgery? Can they handle physical activity without problems? Risk factors are typically categorized into 3 levels: minor, intermediate, and major. Uncontrolled blood pressure, defined as 180 to 110 or greater, is classified as a minor risk condition. However, the AHA guidelines include a statement that blood pressure should be brought under control before any surgery is performed. For patients who have hypertension, there is little to no risk of infection beyond that of a healthy patient. Antibiotics are not indicated. Hypertension rarely causes concern for bleeding after dental procedures. A patient with hypertension who has cardiovascular comorbidities, such as previous MI or stroke, may be taking daily aspirin or another antiplatelet agents. Surgical procedures can be performed normally under these circumstances. Patients with blood pressure less than 180 to 110 can undergo any necessary dental treatment, both surgical and non-surgical, with very little risk of an adverse outcome. For patients found to have asymptomatic blood pressure of 180 to 110 or greater, elective dental care should be deferred, and a physician referral for evaluation and treatment within 1 week is indicated. Patients with uncontrolled blood pressure associated with symptoms such as headache, shortness of breath, or chest pain should be referred to a physician for immediate evaluation. In patients with uncontrolled hypertension, certain problems such as pain, infection, or bleeding may necessitate urgent dental treatment. In such instances, the patient should be managed in consultation with the physician, and measures such as intraoperative blood pressure monitoring, ECG monitoring, establishment of an intravenous line, and sedation may be used. The decision must always be made as to whether the benefit of proposed treatment outweighs the potential risks. If treatment of a patient with upper-level stage 2 hypertension is provided, it may be advisable to leave the blood pressure cuff on the patient's arm and to periodically check the pressure. If the blood pressure rises above 179 to 109, the procedure should be terminated, the patient referred to his or her physician, and the appointment rescheduled. For all patients, the dentist should make every effort to reduce as much as possible the stress and anxiety associated with dental treatment. This consideration is of particular importance in patients with hypertension. A critical factor in providing an anxiety-free situation is the relationship established among the dentist, the office staff, and the patient. Patients should be encouraged to express and discuss their fears, concerns, and questions about dental treatment. Because some antihypertensive agents, especially alpha blockers, alpha-beta blockers, and diuretics, tend to produce orthostatic hypotension as a side effect, rapid changes in chair position during dental treatment should be avoided. This effect can be potentiated by the actions of anxiolytic and sedative drugs. Thus, when treatment has concluded for that appointment, the dental chair should be returned slowly to an upright position. After sufficient time to permit adjustment to the change in posture, the patient should be physically supported while slowly getting out of the chair to ensure that good balance and stability have been regained. A patient who experiences dizziness or lightheadedness should be directed to sit back down to allow safe recovery of equilibrium. Profound local anesthesia is critical for pain and anxiety control and is especially important for patients with hypertension or other cardiovascular disease to decrease endogenous catecholamine release. The effectiveness of local anesthesia is enhanced by the inclusion of a vasoconstrictor in the local anesthetic solution, which delays systemic absorption, increases the duration of anesthesia, and provides local hemostasis. These properties allow for enhanced quality and duration of pain control and markedly facilitate performance of the technical procedures. Thus, the advantages of including a vasoconstrictor in the local anesthetic are obvious. Concerns have emerged, however, that the use of local anesthetic with a vasoconstrictor in a patient with hypertension could result in a potentially serious spike in blood pressure. Oral complications have not been associated with hypertension itself. The development of facial palsy has been described in the occasional patient with malignant hypertension. Excessive bleeding after surgical procedures or trauma has been reported in patients with severe hypertension. However, such bleeding in this patient population is uncommon. Patients who take antihypertensive drugs, especially diuretics, may report dry mouth. Mercurial diuretics may cause oral lesions with an allergic or toxic basis. Lichenoid reactions have been reported with thiazides, methyldopa, propranolol, and labetalol. ACE inhibitors may cause neutropenia, resulting in delayed healing or gingival bleeding. Angioedema, a persistent cough, and oral burning sensations are also associated with ACE inhibitor use. Thanks for joining us today for this important discussion on hypertension management in the dental setting. We hope this video has equipped you with valuable knowledge to provide safe and effective dental care for patients with high blood pressure. Remember, by working together with your patients and their primary care physicians, you can ensure a positive dental experience for everyone. We appreciate you tuning in. Until next time, take care.